Welcome to Good Tech, Compassionate Healthcare, an AMS healthcare podcast that explores the convergence of technology and compassion in healthcare. We host conversations between leading researchers, scientists, and healthcare providers as they confront the challenges threatening our current and future healthcare system, especially in the face of the pandemic. We see an incredible opportunity for digital health to innovate medicine and clinical care, healthcare education, home care, and beyond. That said, we hope to foster an open-ended discussion about how to integrate technology into the healthcare system in a way that enhances and doesn't diminish compassionate care, ultimately improving the experience of patients, caregivers, and healthcare providers alike. If there was ever a time to uphold compassion as the bedrock and guiding principle of healthcare, it's now. Join us now to explore Good Tech, Compassionate Healthcare, brought to you by AMS Healthcare. In this episode, Dorothy Kessler, assistant professor at Queen's University and affiliate scientist at the Bruyère Research Institute in Ottawa, and Babak Taati, scientist at the KITE Research Institute and assistant professor at UofT in the Department of Computer Science and Biomedical Engineering, discuss the research they are engaged in as AMS Healthcare AI and Compassion Fellows. They are both involved in groundbreaking research using technology to improve the quality of life for the aging population, both at home and in long-term care facilities.
Hi, my name is Dorothy Kessler, and I'm an assistant professor at Queen's University and an affiliate scientist at the Bruyère Research Institute in Ottawa. And I'm also excited to be an AMS 2020 Compassionate and Technology Fellow. My research focuses on enhancing engagement in personally valued activities among older adults with complex health conditions, such as stroke, Parkinson's disease, and dementia. And I'm particularly interested in interventions and technologies that integrate a compassionate approach to promote patient autonomy and competence, such as coaching and self-management. And my interests focus from my clinical experiences as an occupational therapist.
My name is Taati, and I'm a scientist at the KITE Research Institute, which is the research arm of the Toronto Rehabilitation Institute at UofT. I also have an assistant professor status at UofT in the Department of Computer Science and in Biomedical Engineering. And last but not least, I am an AMS 2020 Compassion and Technology Fellow. My work is on developing and validating technology and in particular computer vision technology for an aging population. And the goal is to improve the quality of life for older adults and people with a physical or cognitive disability, for example, dementia, and also improve the quality of life of their family members and caregivers.
So, Babak, it sounds like there's a nice overlap perhaps between our work.
Absolutely.
My current project with AMS is focusing on compassionate use of home monitoring technologies. So I'm involved with researchers at Bruyère who have, and across the States actually as well, and they've installed home monitoring technologies in people's homes. And some of these technologies are things like pillboxes. So that they are pillboxes with sensors that can tell if someone has opened or closed the pillbox. It might be sensors on the wall that can tell if a person enters a room or leaves a room. There's some that are spaced out that can measure walking speed. There's a scale so that weight can be monitored as well as body mass index. And also a sensor to tell if you've left the house. So there's different types of technology that are being used. The idea of this technology is that the hope is to be able to keep people in their homes longer. But it also, my particular interest is with people who are experiencing cognitive challenges or cognitive decline and may progress to dementia. Those people want to stay in their homes as long as possible. My work is really to look at the patient side of it. What do people want from these technologies? What kind of information would they find helpful or their caregivers find helpful in terms of helping them to keep as independent as possible and maintain living in their home as long as possible?
That is very interesting and also very useful. I have a couple of questions. What are some of the challenges that you've come across in your research? And I'm especially interested in hearing your thoughts and your research findings about acceptability of monitoring technology in the home and how you and end users of this technology make the trade-off between usefulness and benefits and also privacy concerns on the other side.
Yeah, it's a very, very good question. And I think that's where my research is focusing because I'm really looking at the user perspective. We're just in the midst of the project right now, and we're interviewing people who on tests maybe score lower than expected in terms of their cognitive abilities. Some of them have actual diagnosis of mild cognitive impairment. And we're talking to them about how useful they see these technologies, what concerns they have in using them. And some of the interesting findings are that are coming out so far is that because they trust the research team so much, the people that come in are really friendly, helpful. They have a really nice relationship with them. They're not so concerned about privacy or the use of the information. Many of them, I think, they're not experiencing major difficulties yet with sort of day-to-day activities, and they're not identifying key things that would be helpful to them. But if we ask them about, what might be helpful for someone that is providing care, they can see a different perspective in terms of, they can know if someone gets up in the morning, there's sensors under the bed. They can know if someone hasn't left the house or if they've not entered the kitchen for a few days. So that might be a sign that they're not eating. They can see some use to it. I think the surprise to me was that they weren't really concerned about the privacy aspect.
That's very interesting. So you mentioned some of the potential benefits to patients. Do you want to maybe expand on a particular technology? Because I'm curious to hear exactly how this kind of technology is implemented and what the end goal is. How do you provide feedback to people? How do you provide them with information that you gather from this kind of technology?
At this point in time, it's really in the preliminary stages so that the researchers are gathering a lot of information. The idea at the start of the project was really to be able to help to monitor people's abilities. If someone has some memory impairments and they're going to visit their doctor, they may not be able to kind of accurately recall sort of, what they did over the last week or even yesterday. Most of us can't remember what we ate yesterday, but there's stories that they tell. The healthcare providers don't have a clear idea how accurate they are. Are they taking their pills or not? And they may say they are taking their pills and they may not be. What this technology can offer from a healthcare provider point of view is just a more accurate picture. Through gathering up the information, they can get an idea of, is this person, are their abilities actually staying the same or are they declining, and what rate are they declining? So this is really helpful, I think, from a healthcare provider point of view. And my interest is a bit more from the patient side, in terms of how they might like to receive the information. And we're trying to gather that information and the idea being to try to develop some sort of tool or framework that people developing these types of technologies in the future or implementing them once they get ready to actually be implemented into practice, that they can use to guide them through how to engage the patients in the conversation and how to determine, what kind of feedback would the person like? In what way would they like to receive it? Is the person very technology savvy? Do they have a smartphone or a smartwatch or something like that they would use? Or are there other means that they would like to receive the information? So this is the work that's ongoing. I don't have the answers to that yet, but I think it's really interesting. And we need to keep that in mind that different people will have different needs and ways that they want to receive information.
I see. So, and if I understand correctly, then you plan to have different and separate interfaces to provide information to family members, to the end users, and to the clinicians. They might be receiving different information.
It needs to be tailored to the person, right? Based on what they want, what they see as useful. And you're right, like healthcare professionals and the person themselves or their family members may find different information useful. And the way they receive it needs to meet sort of their needs for being able to monitor or take in, process the information and be able to use it. So I think that's really still in the preliminary stages of what that might look like. But I think it's important to think about different interfaces or different ways of providing that information.
Your own background is in occupational therapy, but you're working on the developments and application of technology. So I assume that you collaborate and work together with engineers or technology experts. Is that correct? And how do you find that collaboration experience?
I think it's a really nice mix. On the team are certainly technology experts. There's the doctors that provide the care. As an occupational therapist, I'm really interested in helping people maintain their abilities and continue to be engaged in the things they want and need to do. Technology can play a key role in that. And so it's very interesting to sort of discover what's possible, right? Because what I think might not be possible could actually be possible from a technology point of view. So it's been a fantastic learning in that way and just thinking a bit, being able to think more creatively about what might be some solutions that people can integrate.
That's very cool.
Yeah. So I read a little bit about your work, and I think there's some alignment there. Can you tell me a bit more about your work?
Yeah, absolutely. There's quite an alignment. Like you, my work is also very interdisciplinary. I'm a technical person, but I work very closely and together with a number of different clinicians with different backgrounds, from geriatric psychiatry to psychology and so on, occupational therapy, speech-language pathology. As I said, and as you know, my research is about developing and validating and hopefully deploying and implementing computer vision systems that support older adults and people with dementia or physical chronic conditions, for example, Parkinson's disease or ALS. And the goal is to improve the quality of life for older adults and people with a cognitive or physical disability, and also to improve the quality of life for their families and caregivers. So I said I use computer vision technology in my work. And to give you some context, computer vision is trying to give computers the ability to see, meaning to analyze and understand images and videos. So in my work and together with my clinical collaborators, we develop and validate computer vision technologies and algorithms that track and analyze human body movements. In our work and in collaboration with our clinical collaborators, we develop and validate computer vision algorithms to track and analyze human body movements. For example, walking, facial movements, facial expressions, sleeping. And the goal is to develop algorithms for clinical assessment, medical diagnosis, or safety monitoring applications. So one example is pain monitoring for older adults with dementia who might not be able to verbally communicate their pain.
Right.
Yeah, pain is very common in old age. There's a lot of research showing that pain is underdiagnosed and undertreated for older adults. And that is especially the case for older adults with dementia who can't verbally express their pain. And in long-term care in particular, the majority of people have dementia. In Ontario, for example, depending on the home, somewhere between 60 to 80% of residents have dementia.
That's quite a high number, eh? It's a really important problem.
Absolutely.
Yeah.
So we want to be able to develop technology that uses ambient monitoring to detect facial expressions of pain and alert care staff when a person needs attention.
So when you say ambient monitoring, is that kind of the vision technology you're talking about?
Exactly. So the idea is to have cameras in common areas. For example, we can use the security cameras that are already installed. And there'll be an algorithm that analyzes the images live and detects faces and tracks facial movements and automatically detects when expressions of pain are present. And when somebody shows sustained expressions of pain over several minutes, for example, then we can notify staff. Obviously, there are validated clinical tools for staff to detect facial expressions of pain for people with dementia. But it takes a lot of time for staff to go room by room and check on each resident for facial expression of pain. And doing that regularly, obviously, is very time consuming. So we want to use this technology to help care staff be able to go and attend to the person who is most likely to need their attention.
I think too, it would be maybe hard, like you may have to have training or really be focusing into to be able to say, is that pain, right? That must require a bit of training.
So there's training involved to be able to make that decision clinically. So for this project, I'm collaborating with Dr. Thomas Hadjistavropoulos, who is an expert in pain, especially pain in dementia. And together we collected a large amount of videos of older adults with and without dementia under various conditions, with pain and also without pain. And all of this data, frame by frame, the videos are annotated for the level of pain that the person is expressing. We use this data to train machine learning algorithms that look at these examples and learn what a facial expression of pain looks like. So later on, when the camera is up and running, when the algorithm sees a person showing an expression of pain, it detects it, and it can automatically detect that this person is showing a sustained expression of pain over several seconds or several minutes. Another example of using computer vision systems in long-term care is trying to automatically identify people who are at a high risk of falling, so we can alert care staff so they can go attend to them and hopefully prevent falls and injuries that result from falls. Because as we know, falls are one of the main causes of injury and even death in older adults. And we want to be able to identify who's at a high risk of falling and be able to attend them, maybe do a physical checkup. Maybe there's a new medication they're taking that is having an effect on their balance.
Important, I think when you're talking about the pain and the falls, it's so important because if you think someone has a fall, that can kind of really impact their overall health and chances of even of survival, right? People after a fall actually tend to deteriorate fairly quickly in their health and abilities.
Absolutely. Is a major cause of concern in older adults. And it goes both ways. First of all, people fall and they get injured. That's a major problem. But also fear of falling is a major hindrance in preventing people from being mobile and active. So there's got to be a sweet spot in between that you are safe and you can walk and you're not overly protective, but also you're not falling.
Right. And I think that fear can go on both sides, right? It can be the person themselves being fearful, but also I recall when I worked in clinically, there's this big concern about, from a healthcare point of view, is this person going to fall? So I think anything that can help to predict that would be really valuable.
Yeah, for this project, I'm working together with Dr. Andrea Laboni, who's a geriatric psychiatrist, and a number of other collaborators. So what we want to do is use ambient monitoring technology to monitor people's gaits and how their gait changes over time and be able to say this person's gait has changed over the past few days such that we think now they're at a higher risk of falling within the next few weeks. Because the problem with existing clinical assessments of fall risk is that they give you a risk of falling that is over a very long period, several months to a year. With that score, everybody or the majority of people in long-term care are at a high risk of falling. And that's not really an actionable piece of information, because if everybody is at a high risk of falling, what are you going to do with that information as a caregiver? Whereas if you can say, we can use ambient monitoring technology and say, we've monitored everyone based on changes in gait and based on all the available information that we have, medication, history, demographics, and so on. We think this person and that person are at a particularly high risk of falling over the next week or over the next month. Then the care staff can focus their attention on that person and go maybe do a physical checkup, maybe do a medication review, and make a decision based on that. So it's again about trying to help clinicians provide a better care.
Right. If you notice that change, then it would be really important to sort of review what's happening with this person, right? Even something like an infection could all of a sudden change your abilities and put you at risk of fall. So being able to detect those things, I think, would be really important. Something you made me think about was that the idea that most people in long-term care are at risk of falling. And then what do you do about that? Because you want to protect them, and clinicians do tend to be a bit overprotective. Do you try to keep them from getting up and moving, right? And we know that that's not going to be helpful in the long run. Can you talk a little bit about how this technology may be helpful with those types of decisions?
That's a good point. So this technology could potentially also be useful in identifying people who are not at a high risk of falling. So then that will relieve some of the worry about risk of falling for those individuals. Another interesting thing that we're looking into is to explore what kind of features of gaits the algorithm looks into and compare that with the features of gait that clinicians look at and see if we can maybe learn something from each other. Maybe there are some things that clinicians look at based on their expert knowledge that the algorithm misses, but there could also be some things that the algorithm notices that there might be very subtle movements that might be difficult to see, but maybe we can pay more attention to them. This is also an interesting area of research that we're looking into.
So that could be another tool for the clinicians in terms of their assessment process.
Exactly.
If you find these conversations interesting, check out the AMS Healthcare website at amshealthcare.ca. There you will find information about our various funding programs, our 39 funded grantees and fellows in AI and compassion, and a wealth of resources on compassion and technology in healthcare. Now back to the conversation.
As you were talking about at the start, you were talking, and you asked me, were there concerns? And I'm wondering, one thing that people told me when I asked about the privacy concerns was that they weren't being videoed, so they weren't as concerned. But in your case, people are being videoed. Is this a concern with respect to privacy for them?
That's a good question. So at the moment, everything we're developing is for long-term care is using cameras in common areas. So for example, for monitoring gait, we have cameras in the hallway, and every time a person walks by, we capture their gait. So there's less of a concern in common areas than in private rooms, of course. And the same thing for pain management. But the other thing that we're working towards is trying to do all the processing on board. So no images are ever sent anywhere or seen by anyone. So there's a little mini computer on the ceiling that processes the camera feed. And the only thing that comes out of that is a fall risk decision.
So it's not going to be somewhere out there on the web. It's actually very localized.
Exactly.
Yeah.
So you can make, the goal is to develop this as kind of a sensor. That if somebody walks by, their gait is sensed, and the signal that comes out of that sensor is a fall risk score. The best performing machine learning model that we have right now combines information from changes in gait and also antipsychotic medication intake.
So antipsychotic medications can be a predictor of falls.
Exactly. So antipsychotic medications are a predictor of fall. And a really important predictor of fall is a history of falls. An important question was, do we gain anything in addition to that by keeping track of gait and changes in gait? And our research shows that, yes, we do. If we have information about history of falls and antipsychotic medication, adding information about gait and changes in gait further improves the accuracy in predicting falls.
Interesting. I'm probably getting a little ahead of you in your work, but I'm thinking, so if we can detect pain and treat the pain, maybe with proper medications, because I can see that if someone's in pain and you're the care provider and you go in to say, get them up and washed and dressed in the morning, they're in pain, they may not be very happy to be moved, and you might get some behaviors that might be labeled as inappropriate or disruptive. And then you might get put on medications to help manage that behavior. And this could lead to falls. So I'm just kind of thinking this is probably a little ahead of where you're going, but I could see it all coming together at some point to be really important for improving the quality of life and quality of care.
Absolutely. Very good points. So untreated pain is a cause for agitation and frustration. Also, in some cases, aggression and violence, which is unfortunately sometimes common in long-term care.
Yeah.
So we're hoping that by improving pain management, we will also reduce those instances of agitation and aggression. And that will be obviously good for the person whose pain is being treated, but also for other residents and caregivers, and improving their work environment and their living environment as well.
This is really fascinating.
Let me come back to you, because we are talking about compassion and applications of technology in providing compassionate care. Where do you think this kind of technology that you're working on leads to in future, and how you'll be able to provide better care?
When I think about compassionate care, I really think about the person being at the center of it, and the person being involved in maintaining their autonomy, their choice and control, and having some decisions in what happens to them. And we know as people's memory and sort of cognitive abilities decline, they tend to get left out of the decision. So I think it's important to find ways to engage with them and to even determine if there are preferences earlier on, finding ways to engage them through the technology or through providing them with information, having conversations. I think that's one aspect that I'm really interested in from a compassionate point of view. I think the other point of view is just if a technology can enable people to be in their homes, to do what they're doing for a longer period of time as they age, I think that's really going to improve their quality of life. So in that way, it's compassionate. So whatever we can do as healthcare providers and using the technology to support people, I think that's really a critical aspect to it. What about you in terms of the compassionate side? What are you seeing?
I fully agree with everything you said, but I also want to add that this kind of technology also helps with caregivers and family members. So, for example, if you can reduce instances of aggression and violence, that obviously is a benefit for other family members or other residents in long-term care. Or if you can provide prompts to caregivers saying this person or that person might need your attention, that will help them to attend to those people and be able to spend their time more efficiently. That will also be useful.
Right. You're capturing really important part. We want to provide good quality care, right? And healthcare providers want to be there for their patients. And so if you can really help them determine who needs the most care at this point of time and be able to attend to really important things like pain and fall risk that are going to impact health overall, maybe there's a way to kind of balance that care and provide, those few more minutes of time that someone might need.
I think the whole point of this kind of technology is to help clinicians, not to replace the clinicians, but also provide additional information that they can use it to manage their time more efficiently.
And when I think about study, you're talking about sort of the long-term care environment, and what I'm looking at the moment is in the community. But I think there's two kinds of care providers, right? There's the healthcare providers in the community, and then there's the family members. And I think, sometimes if you are a family member caring for someone with cognitive decline or dementia, there's a lot of worries that go on, right? I think that if this technology can help you be aware of, did my mom take her pills today? Was she in bed most of the day? Is there no movement in the apartment? Well, that would be a really clear signal that you need to get emergency services there, right? So I think it could provide a lot of relief. Is she in pain? Right. Yeah, you could pick that up. Your technology could be applied there too as well. Oh, yeah. Even the gait monitoring, I think, in the home could be translated to that environment at some point too.
A lot of the technologies that we're developing for home use, instead of ambient cameras, we're developing web apps that the person can come sit in front of the app and we can use it for an assessment, for example, for orofacial assessment.
Right.
To track changes over time or response to rehabilitation or response to new treatment medication or how the disease is progressing over time.
Right. So it's more of a contained point in time versus watching them walk through the house. Right.
Exactly. But there's definitely room for using this kind of technology in the home as well in some more controlled settings.
Fantastic. So Babak, what are your thoughts on, given that there's shortage of long-term care beds, there's staff shortages. I mean, we want to retain staff, we want them to work efficiently, but there's a lack of people to fill positions in long-term care in the community. Mm-hmm. How can your technology help with that in terms of care?
So the goal is to combine information from various kind of sensors, ambient sensing, computer vision technology, but also the kind of sensors that you're working on, wearables, sensors on the walls, on the bed, on the fridge, and so on. And to use all this information and use some artificial intelligence or machine learning algorithm that can use this information, process it, and provide some meaningful information to clinicians such that they can make more efficient decisions and more informed decisions.
Right. And maybe I'm just thinking sort of too, there may be some prevention, right? So if we can prevent the loss of ability, so we see that someone's gait is starting to decline, if we get perhaps that person to an exercise program or a therapist goes into the home to work with them, if we can take a more health promotion point of view through using the information from the technology, that could be useful as well in terms of what are the care needs that people need and trying to minimize those down the road.
Absolutely. And we can also use this kind of technology to track and measure quantitatively and objectively measure responses to different treatments. And that will also help us make decisions about what kind of treatments are more effective and efficacious.
Right. So we put our time and resources into the most effective.
Exactly. Absolutely. Absolutely.
Yeah. This has been a really fascinating conversation, Babak. I've learned so much from talking to you.
Yeah, absolutely. It was a wonderful, fascinating conversation.
Yeah.
And I really look forward to reading and hearing more about your work.
Yes, likewise. And I hope we can maybe collaborate at some point in the future.
That would be wonderful.
All right. Thank you.
Thank you.
Thanks for joining us for this inspiring conversation on the inroads these talented researchers are making in the use of technology in compassionate elder care. And a big thanks to Dorothy and Babak. Please connect with us again for the next AMS Healthcare conversation on Good Tech, Compassionate Healthcare.